EEG, which stands for electroencephalogram. So as you may know, we can listen to the heart with a stethoscope. We can view bones with an X-ray, but we can study the brain as it's working using EEG. So I'm going to show how we're able to record brain waves and what those records show and how EEG is kind of vital to patient care. So before we get started, I'll just introduce a little bit about myself. My name's Kat Kinnard. I am from New Orleans, Louisiana in the United States. I received my Bachelor of Science in Neurodiagnostic Technology last May. I completed a clinical internship in New Orleans hospitals doing neurodiagnostics. I worked for Ochsner as a neurodiagnostic technologist for about 3 years, and I have since transitioned into an outpatient clinic. So I have some extensive experience doing neurodiagnostics. Outside of my immediate work, I'm also involved in some neuroscience research, and I am actively applying to medical school. And so whenever I was in high school, even in college, I had no idea that this field had existed. And hopefully today gives you a new area of STEM that you didn't know of before. So before we begin, what even is an EEG? What is an electroencephalogram? So if we break down the word, electro refers to electricity, encephalo refers to the brain, and gram refers to a recording. So the word literally translates to a recording of the electrical activity of the brain. The brain is an electrical organ, which may be a shock to some people, but every thought, movement, memory we hold, it occurs because of the transmission of electricity between the neurons in our brain. So an individual neuron produces signals that are really small, so small that we're not able to detect them from the outside of the scalp. However, whenever millions of neurons communicate to one another and transmit this electricity, we're able to apply scalp electrodes and monitor that activity. So a common misconception is that EEGs are not introducing any electricity. It's not shocking the patient. We are simply placing little cameras recording the electricity that's going on inside of your brain. So I just wanted to share some of the most common reasons people kind of associate with EEGs. Most commonly, an EEG is performed for seizures or epilepsy, and that's certainly a primary reason. However, EEG is used for more than epilepsy. We can evaluate patients with altered mental status, dementia, encephalopathy, which is just a diffuse brain dysfunction. You can monitor people in comas, evaluate sleep disorders, and you can assess stroke and traumatic brain injury patients. So EEG cannot diagnose a tumor. However, it can show some focal abnormalities in the area that would lead to further investigation. So EEG doesn't tell us everything, but it provides a unique piece of diagnostic information that other tests cannot provide for us. So I just wanted to compare EEG to magnetic resonance imaging, which many people are familiar with. These two tests answer completely different questions. So an MRI shows you the anatomy of the brain. It has great spatial resolution. It gives you a detailed image of different structures. That's where you can see whether there's bleeding, any tumors or structural abnormalities. And the EEG shows how the brain is functioning in real time. An analogy I like to think of, an MRI is like viewing a car at a dealership. However, an EEG is taking that car for a test drive, seeing how it functions. So let's get into the nitty-gritty. How do we know how to record these waves? So the diagram is a little daunting, but we place electrodes on the scalp, and to make sure it's consistent, they developed the International 1020 system, and it spaces electrodes at intervals of 10 or 20% given different landmarks on the head. We use the Nasian and the Inian on the back of the skull, and then the 2 preauricular points, and we take 10 to 20% of those measurements to know where to place our electrodes. And then each electrode location also has a name. The letters correspond to different regions of the brain. So these electrodes that say FP, that's for frontopolar. F is frontal, C is central, T is temporal, A is auricular, which is just the ear. Those are used kind of as a ground. And then T is temporal, P is parietal, and O is occipital. And the numbers tell us which side of the head you're on. So the even numbers are going to be the right side of your head. The Z is the midline or the vertex. And then the odd numbers are the left side of your head. So this allows neurologists worldwide to kind of interpret the same readings using an international system. So each wave has a characteristic frequency, and it's also seen at a different state of awareness. So delta is the slowest wave seen, and they're most commonly seen with deep sleep. Theta comes next. It is seen with increased awareness. Paradoxically, it's also seen in drowsiness and light sleep. Alpha, you see in relaxed wakefulness, and especially whenever the patient has their eyes closed. And then beta is faster. It becomes more prominent when you're alert, when you're thinking or concentrating. And then gamma is the fastest. It's thought to play in higher cognitive functions, and it's only seen directly on the cortex. So if you're placing like cortical electrodes, which is not done in routine EEG, so we don't see gamma waves. Now, no wave is better than the other. There's no hierarchy. The brain naturally shifts between these different wavelengths because these rhythms just depend on what we're doing. So let's look at this first real EEG. This is an example of a normal awake patient. You can see these polar movements. That's them opening, closing their eyes. And just notice that this tracing has an organized appearance. It isn't perfectly straight, but it isn't random. There's a rhythmic pattern, particularly if you look in the back. You can kind of see how it's organized. If you look on the far left, they have the lettering. And so if you're looking at like P3, P4, those electrodes, you see the posterior dominant rhythm. So that's that alpha rhythm we see whenever patients have their eyes closed and they're relaxed. And it's really healthy. And that's one of the things we look for to make sure it's there. When looking at an EEG, it's a little daunting at first. However, you're looking for, is it symmetrical between the left and the right? So remember, the odd numbers are the left side of the head, and then the even numbers are the right side of the head. So this montage or this organization of the waves kind of puts the left side of the head over the right, and so you're easily able to compare the two. And it's really nice. We also look whether the background is appropriate for age and your level of consciousness, which all of the EEG examples I include are adult. Pediatrics and neonates are a completely different world. And so today we're just briefing on adult EEGs. So this organized background tells us that the patient is awake. We see here that they are closing their eyes and they are relaxed, and the brain is functioning normal in this. So let's get into sleep. As we get drowsy and begin to sleep, the EEG changes. So stage 1 is the lightest stage of sleep, and it serves as the transition between wakefulness and sleep. So you can see here these vertex waves. They're called vertex because they're most prominent. If you look at the FZ, CZ, CZ, PZ chain, they're most prominent there, although they kind of have a gradient throughout the brain. So alpha activity begins to disappear. If you look at those posterior chains, you don't really see that nice alpha anymore. You're kind of seeing more theta frequency activity. And so we know that the patient is becoming drowsy. So most of us pass this stage without reasoning or realizing it. And it's also the stage where people experience that sudden feeling of falling before going to sleep. All right, stage 2. So as sleep becomes deeper, we enter stage 2 sleep. And it is characterized by 2 hallmark EEG findings. So you see here these high amplitude K complexes, and followed by these little spindles. Those are sleep spindles. And so sleep spindles are brief bursts of fast activity, somewhat in the beta frequency range. And the K complexes are these large, high amplitude waveforms. They kind of remind me of The Lion King, the scene where they had Mufasa up. Whenever I see that, I think of that. And so we don't know the exact purpose of these waveforms. However, they're believed to be important in memory formation and protecting our sleep from outside disturbances. So when we see these features, the K complexes and the spindles, we know that the patient is in stage 2 sleep. And if you kind of look here, just directly to the left of where you see those waveforms, you can kind of see that there's a little vertex wave trying to come through if you look at the FC, CZ, CZ, PZ chains. So on with that, as we go deeper into sleep, we reach slow wave sleep, which is also known as deep sleep. This stage is dominated by these large and slow delta waves. They kind of have some overriding higher frequencies. This is considered to be the most restorative cycle of sleep, and growth hormone is released during this stage of sleep. Tissues are repaired and the body undergoes its restoration processes. So because the brain is generating these large synchronized delta waves, this stage is a very distinctive EEG appearance, and we know the patient is in deep sleep. Moving onward, the final stage of sleep to discuss is rapid eye movement, or REM sleep. And REM is fascinating. The brain becomes highly active, and the EEG, it resembles a wakeful EEG very much, but the body's skeletal muscles are almost entirely paralyzed. And so this temporary paralysis prevents us from acting out our dreams. And because of this unique combination of an active brain yet a paralyzed body, this stage of sleep is sometimes called paradoxical sleep. So understanding normal sleep is important because they provide a baseline, and we need to appreciate a normal record before we're able to recognize and realize what's abnormal. And if you see here, these little spikes, that's the rapid eye movements, which gives the stage of sleep its name. So what about artifacts? You know, technology requires interpretation. The biggest challenge in EEG are artifacts. So not every wave we see on EEG comes from the brain. Artifacts are signals that come from any source other than your brain. So things like muscle movement, eye movement, chewing, sweating, any kind of patient movement, loose electrodes, electrical interference, those are all artifacts. And one of the most important skills is learning to recognize artifacts so you don't mistake it as being abnormal brain activity. In other words, before we diagnose, we have to make sure we're actually looking at the brain. So here is an example of muscle artifact. So remember that muscles also generate electrical activity. And since brain waves, they don't, have such high voltage electrical activity, you're also picking up other electrical activity coming from elsewhere. So this is an example of muscle artifacts. If a patient clenches their jaw, if they tighten their head, or even if they tense their neck, we will have these electrical signals that kind of overwhelm the smaller brain signals. And it appears as this fast, irregular, nasty waves. And so it especially appears in like the frontal and the temporal chains if you look at the names of the electrodes that it's appearing in. So this patient is probably tensing their forehead. Now this is really scary. This is an example of chewing artifact. So every time the jaw contracts, it generates electrical activity and it's picked up by nearby electrodes. So if we didn't know the patient was chewing, this could very easily be mistaken as convulsions or epileptic activity because it kind of has that rhythmic, pattern that you would see with someone having a convulsion or having a seizure. And so it is important to correlate the video because with most EEGs, they also have a video component. So you can kind of see what the patient's doing. And so it's important to note that they are just chewing and that they are safe. Now this one is electrical interference. It's called 60 hertz artifact in the United States, but in the UK and Europe, it's called 50 hertz. It's just electrical interference. So unlike muscle, this kind of has more of a fuzzy appearance. This comes from the environment, power outlets, phones, IV poles, anything that generates electricity can cause this. So notice how regular and repetitive this artifact is in comparison to the muscle artifact we saw earlier. And recognizing this helps troubleshoot the recording. There's some steps you can take. You can unplug things that aren't necessary, and sometimes it gets rid of it. But there's also what we call a notch filter that filters out the 60 hertz frequency, and so it would disappear. Sweat sway. So the final artifact I'm going to discuss, sweat. So as sweat accumulates between the scalp and the electrode, it causes the electrical properties to change, and it causes these slow rhythmical waves. And this could be mistaken for abnormal slowing. However, the patient is just sweating. And some steps you could take, you would just have to cool down the patient. And this is very commonly seen in pediatric patients who are kind of tussling back at you or fighting. And so it's important to know that it's from sweat. They look very dramatic, but it's entirely unrelated to the brain. Now, what is a seizure? We've reviewed normal. Let's talk about when that activity becomes abnormal. So a seizure you can think of as a sudden abnormal electrical discharge within the brain that disrupts normal function. I explain it to my patients that our brain is like a circuit and it communicates with electrical activity within it. And so whenever you have a little glitch or a break in that circuit that kind of propels, it's similar to what's happening electrically whenever you have a seizure. And so normally billions of neurons communicate in an organized and kind of coordinated way. So during a seizure, these groups of neurons fire together in a hypersynchronous and uncontrolled manner. So depending on where that abnormal activity occurs is what the symptoms you may see, what a person may experience. So anything from a brief staring spell to involuntary movements, changes in your sensation, confusion, or just a generalized convulsion. So one point I want to emphasize about seizures is that not every seizure appears dramatically. Many seizures are very subtle and they actually portray, even though they're often portrayed as full body convulsing, some patients may stare off, they may stop talking for a few seconds, or simply become confused and then quickly return back to their normal selves in conversation. So this is one of the reasons that having an EEG is so important, because you're able to detect seizures that may not be observed clinically with your own eyes. So with that, not all seizures begin the same way. There are two major categories of seizures that we'll focus on: focal versus generalized. Focal seizures begin in one specific region, and because different parts of the brain have different functions, the exact location or the symptoms depend on where it begins. So a seizure may begin in the motor cortex, for example, which may cause rhythmic jerking of one hand. In the temporal lobe, it may affect your memory, your emotion, or your awareness. So generalized seizures, on the other hand, involve networks on both sides of the brain from the beginning. They often cause the loss of consciousness and the generalized convulsing we see. So one goal of EEG is helping to determine where these seizures began, so it provides diagnosis and a proper treatment. So here, it's kind of hard to see with an untrained eye, but if you look at the fourth row of waves, you can kind of see the spiky activity, and then it appears again in the sixth row of waves. So notice that the abnormal discharges are kind of localized to one part. It's one region rather than appearing throughout the entire recording, which you would see with generalized. It's in the right temporal lobe here. And so these can have many different morphologies. These are kind of like little sharp waves, but this is not a seizure. This is a little warning sign from the brain, like, hey, this is a little glitch in the circuit that may propel. This is an area of irritability where a seizure may come from. So let's compare that prior tracing to this one. So if you look, you can see that the discharges aren't confined to one area. The discharges kind of appear over both simultaneously, which is characteristic of generalized epileptic discharges. And so with this, you would not really see those focal symptoms. You would see more of the loss of consciousness and whatnot. But again, this is not a seizure. This is just showing, hey, it's an area of irritability, and that area of irritability is diffuse, it's generalized, it's coming from both parts of the brain. So EEG also plays a vital role in the intensive care unit. Many patients, especially those who are very ill in the ICU, can't communicate like you and I. Whether they be in a coma, whether they be encephalopathic, confused, sedated, having suffered a large stroke, they experience severe injury, they can't communicate. And so sometimes patients continue to have seizures without visible movements. This is also known as non-convulsive seizures, which can only be detected using an EEG continuously. It can sometimes last for hours, maybe even days. And this is a medical emergency that needs to be monitored and controlled appropriately. So this information helps doctors determine whether the treatment is working. It helps them detect seizures. You can monitor encephalopathy, and you can evaluate comas, and you can also identify those non-convulsive seizures. And so status epilepticus is a continuous state of seizures. I believe they define it as seizures longer than 5 minutes or seizures back to back without returning to baseline. And like I said, sometimes there won't be apparent symptoms. It's happening in the brain, but we wouldn't know if they weren't being recorded on an EEG. So EEG becomes the patient's voice when they can't speak for themselves, especially in these intensive care units. Now, so one of the most serious applications of EEG is an evaluation of brain function, especially when considering brain death. So brain death is the irreversible loss of all function of the brain, including the brainstem, where our most visceral and primal functions come from, such as breathing, heart rate, those kind of things. It is legally and medically recognized as death. So brain death is a diagnosis made by doctors using some strict neurological criteria. And although EEG in isolation cannot diagnose brain death, I want to make that distinctive. However, EEG can be used as an ancillary test when it comes to kind of considering it and they need additional information. So when there's no measurable brain activity, as we see here, it's very flat or suppressed, attenuated compared to the other tracings we've been looking at. It may show electrocerebral inactivity. So this is one piece of the overall evaluation, and this is never interpreted in isolation. Now, we have scratched the surface of EEG, but I hope you got the appreciation for what these records are. The lines aren't just little squiggles. They are brain waves. This is a language of the human brain. And so we've explored how neurons generate electrical activity. We have explored how EEGs record it, what normal brain waves look like, some artifact to recognize, also abnormal, how EEG helps us diagnose seizures, monitor ICU patients. We've covered a lot today. So I certainly didn't know that neurodiagnostic technology existed, and it has become one of the most rewarding experiences of my life. And I encourage all of you to stay curious. The next breakthrough comes when people ask questions and aren't afraid to explore what people overlook. And so here I included a QR code to a wonderful website that I use myself as well. It's called Learning EEG. It's a website. It's kind of like a self-paced course, and it will give you more information on all of what we've covered today, as well as additional points that I, kind of skipped over, wasn't able to cover today. And it also shows examples of EEGs, which I really like. And even if you go online and look up like EEG library, you can get all kinds of examples of EEGs. So now I'll open the floor. If anyone has any questions, I am more than willing to answer. Thank you guys so much for listening to me today. And thank you, YSI, for having me. All right, let's see. Okay, I may botch your name, but Nahasari has a question. You previously explained that the sudden jerk we experience before falling asleep is caused by our subconscious interpreting the transition into sleep as if we're falling from a cliff. You also mentioned that this happened during stage 1 and is reflective in vertex waves. I'm wondering what actually causes that sudden jerk and before deep sleep, and whether there's a more scientific explanation behind it. That is a wonderful question. And I also wonder if there's any research behind the actual meaning of the vertex waves. And as you said, whether they have any implications in what happens whenever you fall. So that's something both of us will have to look further into. Is EEG used after a seizure to determine if it has occurred or not? Thank you, Rutha. I'm sorry if I botch your names. But an EEG shows from the second you press record to the moment you end the recording. So as I was explaining, it can detect those areas of irritability where a seizure may come from. Unfortunately, it can't record what has already happened. So I like to compare EEG to an EKG. If you're familiar with an electrocardiogram, you're able to see what's going on whenever you begin the recording until you end the recording. However, you're not able to see what has happened previously. That makes sense. However, there is one little loophole, I guess. If a patient were to have a seizure, you put the EEG on, you may see some slowing. It's called post-ictal slowing. And that just means that after a seizure, our brain kind of recovers. Things are slow. You see those delta waves that it resembles what we saw in deep sleep or in slow wave sleep. But you're able to see those things. But that's the one little loophole, I guess, to your question. But in all, no, you cannot see if it has occurred or not. So Miss Evisa asked, how does the EEG work if a patient is able to sleepwalk? So the brilliant thing about EEG is that you're able to wrap the head. So whenever I'm setting a patient up for an EEG and it's going to run, longer than 30 minutes, maybe a few hours, I wrap the head up with some gauze, and they have the head box, and the extender that connects to the actual machine, it attaches to the adapter, so you're able to carry the head box around with you, and you're still collecting the EEG data. So if this patient were to sleepwalk, they were in a sleep lab, they would still be able to sleepwalk, and in fact, we'd be able to see what was going on in their brain as they're sleepwalking. However, it would show some of that muscle artifact I was talking about earlier, because whenever you have movements or anything like that, it does kind of disrupt the signals. But a seasoned interpreter would know how to play with the filters and the different settings and get what they needed to. All right, so Har said, this may sound silly, but do dreams affect EEGs in any way? That is not a silly question. There are no stupid questions. I am a firm believer in that. To my knowledge, dreams do not affect EEGs in any way. However, say a patient were, talking or moving, you may see those little artifacts from those movements or from those actions. However, I don't think it would affect the EEG very much. An EEG doesn't read thoughts. It doesn't read what's going on in your head. It simply shows level of awareness, if that makes sense. All right, Miss Tisha, I'm sorry, said, is this part of the BCI? Any possible projects that you would love to share? I highly appreciated it. Thank you so much. Reach out to me. You can reach out to me. I'm in the Youth STEM Initiative WhatsApp group, and we can definitely talk more about some projects. I know plenty of ongoing projects. As I said, I am involved in all kinds of research, and so I would love to talk to you, and thank you so much. I think that's it. Did anyone else have any other questions? Okay, let's see. Amrutha said, can EEG be modified as a charging station to send signals to brain when brain dead to recharge the brain? That would be an interesting thing to develop. I'm sure if you can manipulate the ground, I'm sure there's a way you could, but no, I do not believe that you were able to recharge the brain. Once you're brain dead, it's irreversible, unfortunately, to our understanding. Anyone else had any other questions? Thank you, guys.
All right, if there are no more questions, we can end it here. Thank you so much, Kat, for that amazing presentation. We learned so much from you over the last 40 minutes or so, and we'd love to have you back at future STEM Quests. For everyone who joined, thank you so much for being here today and for those insightful questions that you asked. I'll share Kat's presentation with everyone in the WhatsApp group chat so you can refer to it later. Lots of very insightful information there that you can refer to later on when you learn about EEGs or related topics. And yeah, we'll see you again for our next session tomorrow. And there's a lot more to come between now and July 25th. So lots of exciting sessions coming up, just like Kat's session today. And again, thank you so much for joining us. Have a great morning, afternoon, night, depending on where you are. And yeah, see you soon.
Yes, and feel free to reach out. Like I said, I'm in the Youth STEM Initiative WhatsApp, so I will send a little chat. Feel free to talk. I'm always open to conversation. But thank you guys so much for coming today.